Welcome. We're here today at the annual Heart Rhythm Society meetings in San Francisco. I have the privilege to be here today with two authorities on the treatment of atrial fibrillation who participated in a Heart Rhythm Society sponsored webinar. And we're here to talk about some of the points we didn't have a chance to cover in more detail. I'm here with Dr. Bill Stevenson from the Brigham and Women's Hospital in Boston, Massachusetts, and Dr. Gerhard Hindricks at University Hospital in Leipzig, Germany. Let me start off with you, Dr. Hindricks. One of the very striking things to me about the European Heart Rhythm Association and the European Society of Cardiology consensus document or guidelines document, on Afib, was the sort of algorithm you all developed to guide therapy for patients with Afib. It's sort of a symptom score. And I think that's such a critical part of the document in terms of how you approach patients, what type of therapies they receive. And so it doesn't matter what their age is, it really focuses on their symptoms more than anything else. Can you tell me how the group of physicians and scientists came up with this stratification scheme?
Mm-hmm. Yeah, that's a very interesting question. And we introduced with the new guidelines the so-called ERA score. And it's a very simple score in order to allow physicians to quantify the degree of impact on quality of life and exercise tolerance quite easily. There are 4 different classes in the ERA score, and it clearly resembles to the New York Heart Association heart failure grading score with class 1 to class 4. Basically, we try to align something in the field of atrial fibrillation to that heart failure score. So there are 4 ERA score classes for symptoms related to atrial fibrillation. ERA 1 means there are no symptoms. ERA 2 stands for just mild symptoms and regular daily activities are not affected by the arrhythmia. ERA 3 means that there is a significant impact of atrial fibrillation on the quality of life, and the ERA 4 score means that the atrial fibrillation has a high negative impact which affects professional daily activities as well. So the goal was to come up with something which allows us to grade the impact of atrial fibrillation quite fast and quite clearly, which can be easily understood and adopted by everybody active in that field.
Now let me just ask you sort of a follow-up question that always comes up in clinical practice. You see a patient who has mild symptoms but is relatively young. So you might be more aggressive about trying to treat that patient, particularly to maintain sinus rhythm. Do some factors like that, or if a patient may be older, they may have more severe symptoms but have multi-system, multi-organ disease, have bad lung disease, have other medical problems. Does any of that also figure into the symptom score, or how do you use that yourself in practice?
The individual situation the patient is in suffering from atrial fibrillation has a significant impact on the therapeutic management of the patient. And we try to more and more individualize the atrial fibrillation therapy on the drug arm, antiarrhythmic drug arm, and on the catheter ablation arm as well. And if I stay to the examples that you give, if we have a young patient affected by atrial fibrillation without any apparent cardiovascular disease and mild symptoms, but affected strong enough to require treatment, my personal intention would be to go a little bit faster to interventional treatment, ablative treatment, because we know that in the young and healthy patients, the outcome is better, the recurrences are lower, and most importantly, the complication rates are lower compared to older patients which may be affected by severe cardiovascular disease. And in such a patient who may have the same symptoms than compared to the young one, I would be more conservative and stay on the drug side a little bit longer or even for long-time therapy, always having complications and risks in mind.
Well, that's a good segue. Bill, let me ask you to talk a little bit about the AHA, ACC, HRS guidelines. I'm going to ask both of you to comment, particularly where you think the document, what guidance the document gives us for AFib ablation. If you could sort of summarize the approach to AFib ablation from this side of the ocean, and then we'll go back to Gerhard and ask him sort of, there are slight differences between the two documents, and I just, maybe some of that has to do with long-term follow-up, but I'd like you to comment on that.
Yeah, well, we'd like to have more long-term follow-up to base these clinical decisions on, but we don't. And but the reality is that there are a lot of people with atrial fibrillation with very significant symptoms, and so it always, in all patient groups, comes down to a risk-benefit assessment. Now, just in the past few years, we've got better data that shows that ablation therapy is superior to antiarrhythmic drug therapy for paroxysmal atrial fibrillation. And so it's appropriate now, I think, that have a class 1 recommendation for patients with paroxysmal atrial fibrillation who are failing antiarrhythmic drug therapy. It's also appropriate that in some patients it may be offered as first-line therapy. Again, careful consideration of risks and benefits. An informed patient, I think, is really helpful in making that decision. We also have data that even as the atria begin to enlarge and dilate a little bit, a little more extensive disease, that atrial fibrillation ablation can be helpful in selected patients. So it's appropriate that the guidelines now allow for those patients to potentially receive catheter ablation as well.
In class 3 indications, patients who shouldn't get AFib ablations?
So clearly if you have a contraindication to a left heart procedure, long-standing persistent atrial fibrillation for many years with a markedly dilated atrium is unlikely to benefit. It's important to weigh the risk-benefit in that group as well, which usually falls on the side of not attempting a catheter ablation procedure.
Now, tell us a little bit about the deliberations for the European guideline document. Slight differences, but how did the committee come up with the final recommendations? What are the thoughts, and what are they?
I mean, first of all, I think it's important, Dr. Ellenbogen, and I'm glad and happy about that both recommendations, the ones from the United States and the one from the European side, simply go into the same direction. The differences at the end of the day are marginal. The US side came up with a class 1A indication for paroxysmal atrial fibrillation after failure of antiarrhythmic drugs. We have a 2A in the same patient, a little bit more conservative. Actually, Bill, I have to say I was voting for the 1A recommendation on the European side, but you need to have consensus. We were a little bit more, opener to accept an indication as first-line therapy compared to the US colleagues, because we put it into the guidelines that it is allowed. It's a dotted line going from atrial fibrillation directly to ablation in parallel to antiarrhythmic drug therapy, indicating that be cautious, consider, think. When you consider it's appropriate, you are allowed to do it. As a class 2B indication. I think that's appropriate, and it reflects what's happening in most interventional labs performing catheter ablation of atrial fibrillation. If we stay in the patient segment that addressed by this part of the guidelines, the outcome of the patients is pretty good. And more importantly, the complication rate is acceptably low in this subset of patients. So overall, I think the US guidelines and the European guidelines as well nicely reflect the transition of an experimental type of therapy that we had like 10 to 5 years ago, more and more into clinical routine.
That was a really nice side-by-side of the AFib part of the guidelines. Now, there is one area where there are some significant differences, though, and that is in the risk stratification scheme. The HA document, HA, ACC, HRS document, pretty much stuck with the concept of using a CHAD score. And then the European guidelines document enlarged that, CHAD's VASC. Not only did they enlarge that by adding more points and making it easier or lower threshold for anticoagulating people based upon adding in age over 75 is 2 points, and thereby 65 to 74 is 1 point, female sex, or the presence of vascular disease, whether it be carotid disease or peripheral vascular disease. But they also had a score for bleeding risk. So really, focusing on this whole concept of benefit risk. I'm interested in what sort of data there is that the committee looked at to make it easier, a lower threshold for anticoagulating patients. What's out there? What should we expect to see in the coming years that's going to show that this is a good risk stratification scheme?
Regarding the CHADS VASC score, I think it is important to realize that for all patients with a CHADS 2 score of 2 or more, everything stays as it was before. So the VASC part of the CHADS VASC is only relevant and is applied in the so-called low-risk patients according to the CHADS 2 score. And if we apply the CHADS VASC into that particular patient population, it will lead to a little bit more aggressive anticoagulation therapy, and that's based on European data that we have gathered over the last couple of years, showing that the stroke risk in subpopulations with a CHADS 2 score of 1 is considerably high and exceeds the bleeding risk. And this is simply, this reflects the new guidelines, the implementation of the CHADS VASC score. There is another significant change in the guidelines related to aspirin. We are a little bit more careful in recommending aspirin for the prevention of thromboembolic stroke resulting from atrial fibrillation, because recent data indicate that aspirin more or less reduces the risk, which is defined by vascular injury, more than the direct thromboembolic risk resulting from atrial fibrillation. So the guidelines, although aspirin is listed in the CHADS VASC 1 point patients, the text says you may favor anticoagulation in these patients as well. HAS-BLAD. The HAS-BLAD score is based on data from the EuroHeart survey, huge European study, and it tries for the first time to address the issue of bleeding risks. We will see. We need to go into prospective studies and have to reevaluate the HAS-BLAD score. What to me is a little bit difficult is that the risk factors for bleeding are more or less the same risk factors for stroke. So prospective data are definitely needed. I'm happy that we have something which goes into that direction. However, I also admit that, as I said before, prospective data are lacking.
I guess we haven't heard the last word on this subject with new drugs, direct thrombin inhibitors, and then someday factor Xa inhibitors. I think the line at which we're willing to anticoagulate patients is going to shift to lower and lower risk patients as the risk of bleeding goes down. Along those lines, I want to ask Bill and then also ask you. We had a number of people who wanted you to comment on whether the burden of AF, or you treated someone with a drug, or even catheter ablation, whether that changes the way you apply CHADS or CHADS VASC. I think it's a very important question. It comes up in clinical practice. So answer, does the burden of AF have any effect, or patient seems to be maintaining sinus rhythm, on how you apply anticoagulation?
So in general, the answer is no, it doesn't have much of an effect. And this was one of the painful lessons from the Affirm trial, that patients who were anticipated to be in sinus rhythm and it was thought that they would have a lower risk could still have embolic events, arrive in the emergency room with their stroke in sinus rhythm. And the presumption is that they have episodes of asymptomatic atrial fibrillation that are unrecognized and still put them at risk. So if somebody has any atrial fibrillation, the treatment is still according to the CHADS-VASC score. Now, will AF ablation change that? Or will AF ablation using an implantable monitor, for example, where you really have a very good idea of if the patient has any arrhythmia and how long, 15 seconds, 30 seconds, will there be some cutoffs defined where after a period of some time it may be safe to withdraw anticoagulation? I think that we're going to see a lot of studies trying to get at those issues, but at the same time we're hopefully going to have better anticoagulants where the risks will be lower, and it'll be easier to anticoagulate and protect people who are at a little bit lower risk than what we may consider now.
Speaking of that, the newest oral anticoagulant, dabigatran, how long do you stop that before you do an AFib ablation? How do you manage a patient who you're going to do an AFib ablation with that medication?
First, Ken, let me say that regarding the withdrawal of anticoagulation in Europe, we have exactly the same perspective as Bill Stevenson has just explained. It's absolutely the same. We approach that from the safe side, and in doubt, we continue anticoagulation in patients. It's a very individual decision-making that we have to cautiously do from patient to patient. What's going to happen with dabigatran? Dabigatran is longer on the market in the United States than it is in Germany. Yeah, it was released there was a positive vote to release it to market just a couple weeks ago. We have in the Heart Center in Leipzig a little bit extended experience in the use of dabigatran. I would like to put it into careful words because it was off-label treatment what we purposely did. That the acceptance of the patients is very, very high. The initial experience that we made with respect to side effects, bleeding, and thromboembolic risks is very, very positive. For the comfort of the patient and for the workflow, the management of the patient in hospital, out hospital, it represents a significant step forward. If a patient who is on dabigatran needs to undergo a small operation, an extraction of a teeth or something like that, it's enough to stop the drug the day before this small operation is done, because the anticoagulation system is competent within 12 hours. And with a certain time window after the operation, when the bleeding risks go down, you reinstall that therapy, and 2 to 3 hours later the patient is again on effective anticoagulation. I personally expect that the use of the new anticoagulation drugs will represent a significant step forward with respect to safety, reduction of bleeding risk, and to patient comfort.
I think we're going to end with one final question, unless, Bill, if you want to comment on any experience you've had with dabigatran.
We have limited experience, but we have done a few AFib ablation procedures now in patients on dabigatran.
Interesting.
And what we have done is stop it for 2 doses prior to the procedure. And then afterwards, I'm a little hesitant right now to immediately initiate therapy. So we heparinize as we had done in the days when we were doing ablations without Coumadin. And then the following morning, no femoral bleeding, no hematomas, then to reinstitute dabigatran the following morning. In a small number of patients, we've not had trouble with that. We've not yet had a tamponade in anybody with this approach, so I don't know what will happen when that first occurs.
And we've done approximately 15 patients, stopping it the day before their procedure, doing the procedure, giving them half dose of Lovenox the night of the procedure, and the next morning, if they look great, putting them on dabigatran and sending them home without any low molecular weight heparin. So far, too, we've done okay. Let me ask you both a final question here that comes up fairly often, and it's an important therapy that we didn't touch upon at all. Gerhard, maybe you can say something about a pill in the pocket, what drugs you use, how you do it, who's an appropriate patient. And Bill, comment on your experience with that as well.
Pill in the pocket is a very important treatment strategy for patients with paroxysmal atrial fibrillation and relatively rare episodes. Rare enough not to recommend routine antiarrhythmic drug therapy, and rare enough not to consider catheter ablation of atrial fibrillation. The optimal patient for a pill-in-the-pocket therapy has paroxysmal atrial fibrillation. He's relatively healthy, and the drug of choice for pill-in-the-pocket therapies are class 1C antiarrhythmic drugs. I prefer flecainide, others prefer propafenone. That means that patients should not have any severe cardiovascular disease, impaired left ventricular function, or severe left ventricular hypertrophy. Especially care needs to be taken in patients post-myocardial infarction, because we know that class 1C drugs can be harmful to these patients. If the patient does not have a significant organic heart disease, we usually explain the strategy to the patient, and we keep the patient on an ambulatory basis in the hospital to give him a test doses. We take an ECG. It gives the patient a little bit of security how to handle the situation, that she or he recognizes intake of 200 milligrams of flecainide are really, at the end of the day, harmless. Then we talk to the patient and explain him what the goals of pill-in-the-pocket therapy is, and we invite him to come back to us to discuss with us the individual outcome. Usually it works quite nice in a significant number of patients, and this is supported by study data. It is a relatively safe treatment strategy, Bill.
Yeah, I agree. I like to, the first time that they have an episode of atrial fibrillation where they're going to try this strategy, we have them come into the emergency room under monitoring, give them the dose of the drug, make sure that, the thing you worry about is it organizing into some sort of flutter where maybe you don't have quite the adequate rate controlling agent on board that you would like. So I like to see the first response in a monitored setting.
So do either of you not give them some additional oral beta blocker or calcium channel blocker with AV nodal blocking properties, maybe a half an hour or something like that before you give the 1C? I think we should make that clear.
Yes, no, you have to give them an AV nodal blocking
yes,
agent.
It's a good point, and we do exactly the same.
Yes.
Good. Well, I think we've had a chance to go through a number of questions that came up from our webinar about a month and a half ago. I want to thank Dr. Bill Stevenson from the Brigham and Women's Hospital for being here and going over the ACC, AHA, HRS guideline statement, and I know you participated in writing that, and Dr. Gerhard Hindricks from Leipzig, who is joining us, who was very involved in the European Society of Cardiology, and European Heart Rhythm Association document. Both very important documents, and are very well worth the read because they're so important. There are lots of important information and good references. I thank both of you for taking time out today. Thank you.
Thank you.
Thank you.